And so this paper took stock of the progress made in maternal and child nutrition in low middle income countries since the previous series in 2013. And the overall assessment, and I'll share a little bit of the data with you, was that variable progress had been made, but there is an unfinished agenda in trying to address this global burden. And our paper specifically also addressed and emphasized the importance of maternal undernutrition. So I'm going to spend a couple of minutes to talk about that particular topic. So for the new paper, we undertook lit reviews, but also data analysis of national data for 50 countries with surveys done at 2 time points, examining the global burden and trends in time. So this was the new part to this paper. On the left here, we describe the distributions of height for age and how they shifted over time in low and middle income countries. And as you can see, there was a right shift, albeit small, in height for age Z-score. So stunting was reduced, and we saw that. But progress was slow for wasting, which is shown in the right with stunting, wasting, and the co-occurrence of the two shown in the bar graph. And so progress in wasting was low, and low birth weight prevalence continued to be high at 14.6% in 2015, with an estimated 22.5 million babies born low birth weight annually. Children who are both stunted and wasted, the prevalence is quite low, but their mortality consequence is really high in this very high risk population. So they're at a 5-fold higher mortality risk. This is just showing similar data, but looking at it by age, and these are patterns of HAZ and WHZ shown in these 2 graphs. Linear growth faltering is depicted in the left graph, which reduced in both the low and middle income country contexts from 2000 to 2015. As you can see on the right, weight for height Z-scores, the age patterns did not change very much over time. And of course, the low and middle income country difference is quite dramatic. There were new results that are still unpublished and under review from the KI Child Growth Consortium of birth cohorts, looking at longitudinal data. These are all cross-sectional, as you know, from DHS surveys. But the longitudinal data show that peak incidence of stunting and wasting actually occurs very early in life, in the first few months. And so that is an important message from the papers. And stunting and wasting is already present at birth. So this condition of low birth weight has associated with it both stunting and wasting of newborns. In terms of the situation in women's nutrition, progress has been seen in terms of reduction in low BMI, but reductions in short stature or low height or anemia is not as good and is slow. And here you see low BMI decreases, as well as reductions in anemia and short stature in the left bar graph. But the cutoff for short height is actually a severe cutoff of less than 145 centimeters, and the reduction there is not very impressive. On the right, we undertook a sub-national analysis to look at the prevalence of low BMI sub-nationally, and as you can see, we identified quite a few hotspots in countries, both in Sub-Saharan Africa and in South Asia. And I'm hoping to discuss this geographic vulnerability and as a means for targeting, especially in interventions such as balanced energy and protein for pregnancy, when we have the discussion session at the end. Weight gain during pregnancy in LMICs, it's a contributor of low birth weight and fetal growth restriction. First and foremost, we identified a big data gap from these locations in terms of knowing what women gain during pregnancy in terms of weight. And these model data by region show that there is suboptimal weight gain in many of the low-income, low-middle-income country contexts. You can see the green and orange lines are where the IOM recommends the minimum weight gain to be based on different BMI categories. And the average weight gains are quite a bit lower in these regions of the world. And then as we've done previously, we continue to look at the socioeconomic inequality and this gradient from anemia in women and linear growth faltering in children is quite stark, with the evidence being stronger in low compared to middle income settings. The wealthiest children, for example, on the right figure, in low-income countries are similar to the poorest in the middle-income country context in terms of height grades, the score patterns, and that just indicates the breadth of inequity and disparities that exist in these populations. Just to focus a little bit on women's nutrition, there is a need to look at life stages of the reproductive period of a woman's life. And each life stage is distinct with specific nutritional needs and considerations, which we should really keep in mind. On the right, the pregnancy and lactation period comprise almost half of the first 1,000 days. And each of these two physiologic states have distinct needs and nutritional considerations. And again, I think when we discuss interventions, it would be good to discuss where there is evidence and policy gaps for supporting these life stages, not to mention that preconception and adolescence are critically important for preparing the woman to begin her reproductive life. In terms of low birth weight, there are two underlying causes of low birth weight: being born too small or too soon, being born too small with fetal growth restriction, or being preterm gives rise to this condition. And I just wanted to emphasize that each of these conditions we talked about in the mother, being short in stature, having low pre-pregnancy BMI, having inadequate weight gain, and having micronutrient deficiency and anemia, are all directly related or determinants of these conditions. And so the main takeaway I think that I want to leave with you are that we understand and can estimate the high burden of maternal undernutrition. It's well recognized, but the global momentum for work in this is needed. Effective maternal interventions and guidelines for their use exist, but nutrition quality and antenatal care is lacking. So we should talk about that later as well. What is needed is first to fill the data gap on birth weight. We don't have good data on birth weight or gestational weight gain or micronutrient deficiencies and patterns or change over time in those. We need to invest in program delivery of known interventions at scale, especially in pregnancy through antenatal care, and focus on the entire period of the 1,000 days rather than siloed approaches for addressing low birth weight only or stunting only, wasting. There's a tension between prevention versus treatment in the area of wasting, for example. The new frontiers are preconception nutrition and adolescent growth. And we also want to support lactation and the vulnerable newborn, the infant in the first 6 months of life that is experiencing growth faltering. And so thank you, and I'm looking forward to our discussion.
Thank you. Thank you very much. And please remember to put your questions into the chat box, and we'll have a chance at the end of the three presentations to ask questions and have the questions answered and have a panel discussion among the three speakers. Our next speaker is Dr. Emily Keats. Emily is the Senior Research Associate at the Center for Global Child Health here at the Hospital for Sick Children. Emily received her Bachelor's of Science degree from McGill University in Montreal. She then completed a PhD also at McGill University. Following her PhD, she undertook a Master's of Public Health, specializing in epidemiology at the University of Toronto. Her research interests fall broadly into the categories of adolescent health, nutrition, gender equality. Emily has experience working and living in East Africa and is an enthusiastic member of the Countdown to 30 Consortium, a multidisciplinary, multi-institutional collaboration working towards achieving the Sustainable Development Goals. And Emily is going to be talking to us about the Lancet 10 Nutrition Interventions, Revisiting the Evidence. Emily, the virtual podium is yours.
Thank you so much, Stan, for the introduction. And just a note to say that this presentation is really on behalf of all of the review authors as well, who are listed on this title slide. So just to start with an overview of my presentation, I'm going to be going over some of the findings from the systematic review synthesis paper published in the Lancet Nutrition Series update. And specifically, I'll walk you through the revised conceptual framework for action, the methods that we undertook to compile results for this paper, and then I'll outline some key findings and effect estimates for select maternal, infant, and child interventions. And I'll conclude with some key messages. So the framework that you're seeing on the screen is the UNICEF framework for undernutrition that was adapted for the previous Lancet Nutrition Series. And you can see that here determinants of optimal fetal and child nutrition and development are grouped hierarchically based on their proximity to the outcome. And then you can see that along the outside, there are lists of interventions and approaches that are acting on these determinants. And these have been grouped into those that are nutrition specific and those that are considered nutrition sensitive based on the determinants that they act upon. In our new framework, which I'll show you on the next slide, we have moved away from this nutrition specific and sensitive language, and we're now classifying nutrition actions into those that are either direct or indirect, and those that are delivered either within or outside of the healthcare sector. And the reason for this was really to overcome challenges around coordination, around investments, and around monitoring. And this is especially important given that so many nutrition actions fall across very diverse sectors. So here's the new framework. It looks a bit different, but you can see that we've still grouped determinants into those that are proximal, underlying, and distal. And the brighter turquoise color indicates these interventions or strategies that are directly affecting nutrition by acting on the more proximal determinants, whereas the lighter blue color highlights the indirect actions that are acting on the underlying determinants. And as mentioned, you can see that we've split these actions into those that are delivered within the health sector along the top and outside of health along the bottom. And so, for example, we have maternal and child supplementation, which would be classified as a direct health sector action, compared to, for example, poverty alleviation strategies, which would be characterized as indirect other sectoral strategies. So the review paper itself was informed by a number of new systematic reviews and systematic review updates that examined the 10 interventions from the 2013 Lancet series, along with some new promising interventions. And these included those that were both indirect and direct, and those that were delivered across the continuum of care, so from the preconception period all the way up to the school age and adolescent period. These reviews focused on low and middle income countries only, and we placed emphasis on good quality efficacy and effectiveness studies that were published post 1995 in order to get a sense of more recent context. Both database and extensive gray literature searches were conducted by topic, and we ended up with 11 nutrition reviews that have been published in a special issue in Nutrients with corresponding Campbell Library reviews, some of which are still forthcoming. So this is just a list of the 11 reviews. You can see they're divided based on population subset, and type of nutrition intervention. But today, for the sake of time, I'll be giving just a quick snapshot of some results, specifically examining multiple micronutrient supplementation in pregnancy, some infant and young child feeding promotion interventions, and then micronutrient supplementation interventions among children under 5. So starting with multiple micronutrient supplementation, since the last Lancet series was published, there have been a number of additional trials that have been conducted looking at MMN supplementation. And so we're now more confident in our assessment of MMN in pregnancy. And this is especially important given that multiple deficiencies are so common among pregnant women in low and middle income settings. So this specific review combined evidence from 33 different randomized control trials, and overall conclusions underscore that MMN should really be prioritized over iron and folic acid supplementation for pregnant women to improve birth and child health outcomes. And these conclusions were drawn from the evidence, which showed a reduced risk of stillbirth by 9%, a reduced risk of low birth weight by 15%, a reduced risk of babies being born small for gestational age by 7%, and probably a reduction in preterm births by 4%. We found that effects were stronger when MMN supplements followed the UNIMAP formulation. And this is the supplement that was created by the United Nations, and it contains 15 micronutrients at specified doses. So we had conducted subgroup analyses to look at UNIMAP supplements as compared to those that were comprised of only 3 or 4 micronutrients. And we saw that UNIMAP was superior almost every time. So this is just an example of a forest plot. This is the analysis showing the results of MMN versus IFA and looking at low birth weight. And the pooled effect estimate, which is highlighted in the blue box, tells us, again, there's a 15% lower risk of low birth weight among the group of women receiving MMN. And as I mentioned, we conducted these subgroup analyses. So the group on the top here represents those trials where the supplement was closer to the UNIMAP formulation. And then the group on the bottom represents trials where women had been given a supplement that contained either 3 or 4 micronutrients only. And you can see that the effect was much stronger for the group on the top. So here, risk of low birth weight was reduced by 21%, whereas for the group on the bottom, there was actually no statistically significant difference in low birth weight between groups. Other outcomes that were improved with MMN supplementation included different maternal micronutrient concentrations, child diarrhea, and executive function among children of mothers who had been supplemented. So some interventions for infants. A review on infant and young child feeding support and promotion examined 38 studies across low and middle income countries that looked specifically at the effects of breastfeeding support interventions. And you can see that these interventions were quite varied depending on the study. So when considering timing of the intervention, whether it was delivered prenatally, postnatally, or in both periods, the delivery mechanism, and the duration of the intervention. And the results are also posted on this slide. So you can see that when study data were pooled together, the review found that enhanced breastfeeding support when compared to standard of care led to a 20% increase in early initiation of breastfeeding. So where the infant is put to the mother's breast within 1 hour of birth. There was a 2% increase in exclusive breastfeeding at 3 months, a 53% increase in exclusive breastfeeding at 6 months. And then also the risk of infant diarrhea was reduced by 24%. And again, just an example of a forest plot showing the results looking at exclusive breastfeeding at 6 months. And here the risk ratio of 1.53 indicates a substantial increase in exclusive breastfeeding among the intervention group. As a bit of an aside, in order to actually achieve the benefits of breastfeeding, we need collective action and better support for mothers, and governments play a fundamental role in this through improving policies and programs that support breastfeeding. So I just wanted to mention the Global Breastfeeding Collective, which is led by the WHO and UNICEF, and has identified 7 policy action priorities, each with an indicator and a set target to be achieved by 2030. So these actions include things like enacting paid family leave and workplace breastfeeding policies, improving access to skilled breastfeeding counseling, etc. And now considering complementary feeding interventions, authors had looked at complementary feeding education alone versus standard of care among food secure populations. And they also looked at complementary feeding education plus food provision in food insecure populations. And what they saw was that complementary feeding education alone did improve mean height for age Z-scores among food secure children, but we saw no effect on stunting or wasting. However, complementary feeding education plus food provision led to a significant increase in HAS, a significant decrease in stunting, and a significant decrease in wasting among these food insecure children. So really highlighting the benefits of this composite intervention that include the provision of complementary foods where household food insecurity is high. And lastly, for the select under 5 interventions. So we reevaluated preventive zinc supplementation in children under 5, applying the review criteria that I mentioned previously, but also important to note that we included studies of healthy children only. So meaning any studies of children that had been recruited based on a pre-existing condition, which could have been a nutritional deficiency, were excluded. And what we found when we reanalyzed the evidence was that zinc supplementation was not associated with a significant increase in height. This actually differed from previous results. So we decided to run a sensitivity analysis where we actually compared the effects among healthy children and children with nutritional deficiencies. And what we saw in this case was that height was improved among children with existing nutritional disorders who had been given zinc. And this is an important finding because it means that preventive zinc should potentially be provided in a targeted manner as opposed to using it as a blanket supplementation strategy, at least for growth promotion. However, we also looked at zinc in the context of diarrhea. And in this case, we evaluated the effects of preventive zinc and therapeutic zinc supplementation. And we found that preventive zinc supplementation reduced diarrhea incidence among children by 11%. And the provision of zinc in a therapeutic manner, so when children are experiencing acute diarrhea, actually reduced diarrhea duration by about half a day. And so lastly, I wanted to touch on a newer intervention, which is small quantity lipid-based nutrient supplements. LNS were originally created to treat acute malnutrition, but in this smaller quantity form, many investigators have set out to better understand how they might function in a more preventive sense. So when provided alongside a regular diet. And as the name states, these are lipid-based food supplements that contain multiple micronutrients, and they tend to be individually packaged like you see on the screen. They provide energy in addition to multiple micronutrients. And so they're typically made up of some combination of peanuts, pulses or cereals, and milk, vegetable oil, and sugar. There's actually quite a bit of recent evidence on the effects of SQLNS in children. And overall, what we found is that this type of supplement is effective for promoting growth. So results on this slide reflect a systematic review that was comprised of 13 studies, and this is the DAS review, an individual participant data meta-analysis by Dewey, and then another systematic review and meta-analysis by Stewart. And from the DAS review, it was shown that SQLNS, when provided to infants 6 to 23 months of age alongside normal complementary foods, reduced moderate stunting by 7%, reduced moderate wasting by 18%, and reduced anemia by 21%. And Dewey similarly found a 12 to 14% lower prevalence of stunting, wasting, and underweight, a 16% lower prevalence of anemia, and a 64% lower prevalence of iron deficiency anemia when compared to control group children. Dewey also looked at some indicators of development and noted improvements in language, social, emotional, and motor development among children who'd taken SQLNS. And then lastly, Stewart's review went so far as to look at mortality risk. And she found that risk of mortality was 27% lower among children in the LNS versus non-LNS arms. So putting these findings together, along with the findings from the reviews, which I haven't discussed today, we assessed whether the 2013 recommendations for nutrition interventions still apply today. And what we found is that they do. So currently we continue to recommend all 10 interventions, and we've added an 11th to the list, which is preventive SQLNS for growth promotion in children. And so the rest of these interventions we recommend include large-scale food fortification for the prevention of micronutrient deficiencies, maternal calcium supplementation, maternal balanced energy protein supplementation in underweight women, maternal multiple micronutrient supplementation, vitamin A supplementation in children where there is deficiency, breastfeeding promotion and counseling, complementary feeding education with or without food provision, preventive zinc supplementation, ready-to-use supplementary foods to treat acute malnutrition, and therapeutic zinc supplementation for diarrhea. So in terms of key messages, we have shown that evidence-based interventions for improving maternal and child nutrition continue to be a combination of those that are direct and indirect, and our evidence supports the continued effectiveness of the Lancet Core 10 interventions with some adjustments of effect sizes. New evidence strongly supports the use of preventive SQLNS for reducing childhood stunting, wasting, and underweight, and the scale up of antenatal multiple micronutrient supplementation. I haven't touched on it today, but if you read the paper and the corresponding reviews, you'll see that evidence gaps remain, particularly around interventions to prevent undernutrition and overweight obesity among the school age and the adolescent populations. And then lastly, newer evidence synthesis methods, which I believe Purnima may touch on within her presentation, really underscore the importance of multi-sectoral actions and the need to deliver interventions through the health sector, but also through other sectors, including social protection, agriculture, WASH, and so on. And so the conceptual framework for guiding this will really help to make this multi-sectoral action more clear. Thank you, and I look forward to the discussion as well.
Thank you, Emily, for your clear and great discussion of the 10 Lancet nutrition interventions. Thank you. We'll have an opportunity to ask you questions at the end. So just to remind the audience, please include your questions in the Q&A. And at the end, we will have an opportunity for each of the speakers to respond directly to your question. The third and final speaker is Purnima Menon. And Purnima is going to be talking about putting the Lancet series evidence in context, insights specifically from India. Purnima is a senior research fellow in IFPRI's Poverty, Health, and Nutrition Division and is based at IFPRI's Asia office in New Delhi, India. She conducts applied nutrition research in the South Asia region with a focus on programs and policies to improve maternal and child nutrition. Currently, Dr. Menon leads a team that is conducting impact and process evaluation of Alive and Thrive, a Bill and Melinda Gates Foundation supported initiative to improve infant and young child feeding and child nutrition in Bangladesh, Vietnam, and Ethiopia. The Alive and Thrive evaluation portfolio includes a set of rigorous impact and process evaluations and cost studies of Alive and Thrive's interventions to scale up and improve community and health system-based behavior change communication interventions to improve nutrition, as well as policy process research methods to measure and document the influence of media, advocacy, and policy support on shaping nutrition policy landscapes. Dr. Menon holds a PhD in International Nutrition from Cornell University and an MSc in Nutrition from the University of Delhi. Purnima, the virtual podium is yours. Over to you.
Thank you so much. Thank you so much, Stan. And it's absolutely wonderful to be with all of you today. So my talk will be a little bit different, although I will share some of the evidence from the Lancet Nutrition series. But mostly I'll reflect on bringing evidence into context and say a little bit about how we can make sure that the evidence from efforts like the Lancet Nutrition series can be used effectively to shape and support nutrition strategies in countries such as India. So let me start first by saying it's really useful for us to just take a step back and to understand the context for taking up evidence on challenges such as malnutrition. In our experience, and I've been with IFPRI in India since 2008, and have had the privilege, in a sense, of seeing all of the Lancet series, each of them as they have come into the knowledge ecosystem in the country, and have really sort of had the privilege of seeing how that kind of evidence gets integrated. And I think what has been interesting to me, and I've kind of put it together in these 4 steps that I think about, is first and foremost the entire policy community, not just one policy maker somewhere in a country. The entire policy community has to recognize that, yes, we have a problem. Those of you who've been following India over the last many years will realize that even acknowledging that stunting was a problem took several years, and it took a lot of work. So once you've acknowledged that there's a problem, the entire policy community then has to agree on drivers and agree on solutions. And that really requires integrating evidence from a range of different bodies of work, not just the Lancet series, although the series has played a tremendous role in sort of outlining solutions. And then we move to the ACT process, where policy instruments sort of uptake and acknowledge and integrate all of this evidence. And it isn't just a major shift. Usually it is an integration and a lot of recalibration that happens there. And then finally, sort of the next step in that process is this idea of monitoring what's going on and then recalibrating strategy. And this process in many places takes many, many, many years. And this ever-evolving scientific base on each of these areas, on the problem, on the drivers, the solutions, the kinds of investments that should be made, is both an opportunity and a challenge. And I think those of us who produce evidence, but then also have the privilege to engage with policy communities around that evidence, should acknowledge the complexity that this is. So where does the Lancet 2021 series fit at this point of time in India? It actually fits on that extreme right-hand side of those arrows, where in 2018, India actually launched a nutrition mission that had a very robust set of evidence-based interventions integrated into existing national platforms for delivery, so on and so forth. And so what the Lancet Series 2021 does is help in the process of recalibration. Luckily, not in the process of recognizing that we have a problem. And to me, given that a lot of the evidence on the efficacious interventions is sort of broadly integrated into the national nutrition strategy here, the kind of evidence that I think is getting traction and will likely get more traction is what is really new in the series this time. And this is the evidence on the real world evidence for successes. The series summarized insights from a total of 15 case studies of large geographic units, countries, and 4 Indian states that had addressed stunting, reduced stunting at scale. And this is in paper 2 of the series. And it did, in my view, a very important job of sort of really highlighting that A, change was possible, and B, also highlighting how important it was to include not just the evidence-based interventions as we typically think about them, the direct nutrition actions, but also the indirect actions that target the underlying determinants, which include poverty alleviation, WASH, parental education. In many cases and in many countries, what we showed in the series was that these things accounted for almost 50% of the observed reduction in stunting. Now, the research team that I work with was privileged to have 4 Indian state case studies integrated into the series. So I just want to say a little bit about that, because I think what that does is actually make it even more promising and interesting for the Indian policy community to engage with the Lancet series and the evidence therein. So the research team that I work with studied, I apologize for the slightly busy slide, but let's focus on the left-hand side of it first. We studied 4 states which were exemplary in reducing stunting at scale. and we put together the findings on that, and we're continuing to sort of engage audiences in India around this still. But what they showed was really that if you move your attention to the right-hand side of the slide, we summarized evidence for 4 states, showing that health and nutrition interventions accounted for anywhere from 11% to 23% of the change that had been seen, and that socioeconomic status, improvements in socioeconomic status accounted for anywhere between 11% and about 30% of change over time, and that maternal characteristics were a very important part of this. What was also interesting, and I think some of the deepening of this work is important when we get to getting policymakers and the policy community to engage, is we're able to localize the Lancet Nutrition Series evidence by helping the policy community in India show that the program and policy evolution that contributed to these changes occurred under common national programs, but that the states that really made progress added on to those programs and also adapted those programs to their own context. We were also able to show that the efforts that led to successful change were shaped by a vision to change some kind of an outcome. It wasn't always nutrition. Sometimes it was mortality. Sometimes it was general poverty and development. But that vision was critical. That bureaucratic capability was very important, and that bureaucratic stability was also very important. This is critical in countries like India, which have civil administrations that are made up by generalists who need to take a little bit of time to understand the topical areas. And if you have generalist bureaucrats who come through a system and stay only for 1 year, you're not going to get the change that you want. We were also able to identify the importance of different types of financing, etc. So one of the things that we're doing is taking the series, but also taking some of the depth of this evidence and trying to move it with the policy communities we work with. Now, as I mentioned earlier, you never know when evidence becomes interesting or useful and engaging to people in a policy community. But in India today, the Lancet Nutrition Series and the importance of what we've learned in the series is, in a sense, getting more traction because there is new evidence on stagnating child undernutrition. And what this does is make the Lancet series findings, especially on the success cases, more compelling and more relevant in context. So for example, what we've seen is that a majority of states for which data has just become available have seen very little change in an outcome such as stunting in the 4 years since 2015 and 2019. But what's also really interesting is again, taking that lens of positive outliers. One is beginning to identify, for example, the large state of Bihar, which carries a very, very large number of stunted children and children really in one of the largest birth cohorts in the country, showed a very nice decline of 5 percentage points in this period. And so we're really able to connect the dots between the exemplars that are in the Lancet Nutrition series and the need to now study exemplars as we look forward. Now, our research team, together with the larger policy community in the context of India, is sort of examining what has happened in the context of these last 5 years. We are collaborating with the exemplars team that is also examining these, and we hope to do more together. But what we're really doing is sort of recognizing that the under 5s that are captured in these new surveys in 2019 were born all the way from 2014 to 2019. India's national nutrition strategy was really only launched in 2018. So we'll be studying, the exemplars and the not so exemplars that, where we haven't seen as many improvements, building on what has been in the series, sort of looking at all the changes that have happened, the evolution of policies, the reach of social sector programs, and the wider economic and social context. So in a sense, the Lancet series also gives us an impetus and an anchor to build out more of these case studies. The last piece I want to conclude with is to bring in the program framework. I thank you, Emily, for referencing that as as nicely as you did, one of the things we've done in India, and again, we're just sort of slowly beginning to discuss this in the Indian context as well, is to take that Lancet framework of direct health sector interventions, indirect health sector interventions, other sectoral strategies affecting nutrition, and other sectoral strategies indirectly affecting nutrition, and then patching into that what is already happening in India and what is not happening in India. And what's really interesting to see is that there's just a few of the direct health sector nutrition interventions that are not currently included in the national policies here. But there is, quite a bit of fairly substantial work to actually be done on the sectoral strategies that indirectly affect nutrition, which is in the bottom right here. And perhaps what's most prominent there is that India's nutrition strategy right now does not include a coupled poverty alleviation strategy. And so, the gap there is really very, very clear. On some of the other things, it's probably much easier to handle, but it probably will take much more effort with the policy community here to move towards the coupling of the nutrition strategy with the poverty alleviation strategy. So let me stop there. I'm really happy to take questions and comments, but I hope this was sort of an interesting view of how we connect, the global with the national, and of course, because India is a big country, some of this connecting is also happening at a subnational level. But thanks for the opportunity to share this here today.
Thank you, Purnima, for your clear presentation in a short period of time. And I do think that it does bring up a number of questions. And again, I would encourage everyone to ask your questions and put them into the Q&A box. Purnima, maybe I can just start by asking you the question. I noticed that the health and nutrition interventions basically accounted for generally less than 20% of the etiology of stunting. Do you think, as a nutritionist, this is going to put us out of business? Or do you think we simply have a harder job to do to take this multifactorial etiology, which involves a lot of different ministries in India, where I think traditionally the ministries may not work that well together? And is that going to be a challenge going forward? That is taking a rather simple notion that stunting is due to malnutrition to a much more complicated notion that stunting is multifactorial, which involves, again, 8 or 10 different large picture issues. And again, if you want to do something about it in an Indian context, and if it's going to be something that's done in the public sector, how do you get the ministries to work together in this complicated multifactorial milieu?
Oh, that's a lot of questions, Dan. So firstly, I don't think it's setting, I don't think the, the findings on the, 12 to 20, 25% contribution of the, the increase in intervention coverage to stunting reduction, that doesn't really set us back at all, because actually the nutrition framework for India is very strongly located around these programs. And in a sense, those numbers to me link up quite well with even what we learned in the, in the previous Lancet nutrition series, right? I mean, there we said it was about 2080, and, we're sort of looking at it a slightly different way. In a sense, I don't think we need to talk to, yes, there's a lot of different ministries, but what's interesting about this particular policy context in India here is that many of those ministries are already delivering programs that have huge potential to address nutrition. And so the discussions we're having are not about getting ministries to do new things, but actually about discussing, how does work happen at local levels to really converge the efforts of different ministries on 1,000-day households. And, that has taken years of work by many different people in the Indian evidence ecosystem to actually articulate the goal of convergence so clearly, to say it isn't about ministries working together, but it's about getting the services of all ministries to 1,000-day households. It is actually very clearly written in the convergence multi-sectoral plan. The challenge, of course, is in getting it done and in getting the data to help us know how well it's going. But I find that a much more promising place to be in conversation with people around than is, where we were 12 years ago or 10 years ago. And Parul probably remembers some of this as well. Are Indian children really that stunted? What do we think about the growth references? That was a much more challenging place to be in than where we are today. So let me stop there, and I guess maybe hand it over to any of the others who may want to take some of that on as well.
Is there anyone else wants to respond to that question? Otherwise, I can go on to another question. But again, my issue was that when you have something that's multifactorial, it's much easier than saying, the problem with this is that we have to get better nutrition into children and that's it, and we'll go on to something else. And clearly that's not the issue. We've known that for a long time, but that's it is hard, I think, to explain that and to get the interventions to recognize this multifactorial notion. Purnima, any comment on that?
So I had a comment.
Please.
This is Parul, yeah.
Oh, sorry, Parul.
No stories. So it's actually not so much a response, but a thought as well with regard to how, poverty alleviation or WASH or maternal education types of things do explain and influence quite a bit the trajectory of change of the burden. But I was also wondering about the timeline of that vis-a-vis what we want to achieve with our SDG targets. And so I think that the nutritional interventions may not contribute or not have contributed in the timelines that were examined precisely because they were not administered at scale. And so here's an opportunity to actually take the 11 samurais, as they were called, and double down on that in addition to all the other things that are happening, which will happen as time passes and they have longer time trajectories. But this is why it's so critical to double down on these nutritional interventions so that we can actually speed up that entire process.
Fair enough. We do have a question in the Q&A, and I'm not surprised this question came up, and you probably won't be surprised either. It said, question to Pearl, thanks. I think your data covered the COVID impact in 2020. Your presentation shows there was deterioration from 2015 to 2020. Were these due to the impact of COVID in 2020 or some other hidden reasons? This is from Khalid Hassan from Toronto.
Yeah, thanks, Khalid. So just to clarify, the data that we examined, since these papers were being worked on for a couple of years, was from 2000 to 2015. So it all is in the pre-COVID era. And so it doesn't, none of the change is explained related to COVID. But in the paper, we do talk a bit about the disruption that is going to be caused with the COVID pandemic to the progress that has been made. However small the progress will be further impacted with COVID, because there will be disruptions to the economy, to employment, to food systems, to social protection programs, health, education. It's going to be a huge systemic impact that we should be prepared for. And what that will do to these, these conditions is going to be something we have to be very well thinking about and preparing for. Otherwise, we are going to have regressed. We will regress years of progress. And so this is a very important point and topic to be thinking about.
Well, just to continue that question, the question I was going to ask you is that when you did your analysis, were there any large data gaps that prevented you from looking at the bigger picture epidemiology, for example, from certain countries, certain regions? Are we getting enough data from DHS? Are there gaps in what we need in order to tell the big story?
Yeah, no, the data gaps are significant. And I think, I mean, that message has been there with the nutrition community for a while. And I feel like, I don't know how to emphasize it and yet not be paralyzed by it. and so I had mentioned data gaps. The low birth weight estimates are really based on, borrowing data from, neighboring regions. They're not collected at the community level. They're collected in hospital contexts where we know only a certain kind of population will come to. There are gaps with understanding micronutrient deficiencies at the population level with biomarkers. We have no way of even tracking any progress or trajectory. Gestational weight gain in pregnancy was another big gap that we identified. The data that I showed is all model data using DHS weights and heights in women of reproductive age, and then doing the modeling based on survey data in pregnant women from very small, studies and things like that. So yes, there is that certainly to be acknowledged, and how we build data systems is a big within countries, and how countries recognize. So when Purnima was saying that these various sectors are already working to make progress, maybe having indicators of these outcomes that we care about within those sectors would allow them to also track their impact on things like stunting and maternal undernutrition and things of that nature. But yeah, I would love for people to come up with global solutions, local through global solutions for the data gap issue.
We may come back to that later. There is a question that Parmi Sachdev asks, and I guess it's kind of related to this issue that we talked about, the multifactorial issues around, for example, stunting. Parmi says, how do we get some of these very important messages to those working outside of nutrition? Purnima or Parul or Emily, anyone can take it. So how do we get these important messages to those working outside of nutrition, that many of the issues that we see that previously we called, quote, nutrition issues are actually much more than nutrition? I think we know that. I'm talking about the nutrition community, but how do we get these messages outside of nutrition is the question that Parmi asks. We'd like to take that.
I can maybe start.
Yeah, go Emily, and then maybe.
Okay. I was just going to say, yeah, I mean, it's a really good question and a really important question, I think. And from some of the work that we've done, looking at the success stories through exemplar countries, I think, I mean, at the country level, I think some are sort of going in this direction and now creating some multi-sectoral nutrition action plans and stuff like that, which span across several sectors and allow for integration in that manner. So I think it's really important at least at country national level to have some sort of coordination body that can kind of act across.
Purnima, do you want to make any comment on that?
Sure. So, I think many sectors are very interested in nutrition and very interested in, for example, studying the heights of populations. Economists have been studying the heights of populations for a very, very, very long time. I didn't even know, for example, until some years ago, that there were this field of economic history that had been studying the heights of populations, etc. Our challenge at some level is, I realized that, when we started doing some of our work in India, is that to really make progress, sort of policy progress on an issue, everyone has to sort of come to some common understanding about, what the problem is, what the drivers are. And we really saw this play out in relation to child stunting in India. It literally, it took 4 to 5 years for not the nutrition community to align. The nutrition community was very aligned, but a lot of policy work in nutrition or policy that affects nutrition happens by the economic community or by, people who are economic advisors to, very senior policymakers. And so until the economists had sort of really sorted through the Indian data and really sorted through this issue of, the heights and there was a whole period when, some economists were really focused on sanitation as a big challenge. Others were focused on gender issues. And there were some of us saying, this is, we have to see the whole elephant. It isn't, this, that, or the other, but this stuff had to play out and really go through the cycle to get to that, level of sort of enough common recognition that, the penny could drop and we could move to that multi-sectoral nutrition strategy that, some people wouldn't tear up and put on the side. And one of the things that I've learned is that actually the nutrition community in any country has to really play the role of being the knowledge broker there, right? We have to be able to say, that's great that you think it's that, and that's great that you think it's that, but, our science tells us that it's all of those things together, and that there is space in the context of our science for the evidence that comes from these different people. And it's sort of been a very interesting journey and a real privilege, honestly, to be able to play some of that, that bridging role. But I think when you work on a complex multi-sectoral issue such as nutrition, it is very important that students who are trained in nutrition value that multi-sectorality and value how important it is for them to learn to play knowledge bridging roles in, in the wider community. And so, I think programs such as yours and at Cornell and, Hopkins and other places, I think we train people to do this. Not a lot of traditional nutritionists get trained to also, value the importance of that knowledge. So I think we have a great responsibility, frankly, in helping people see the whole picture.
Thank you. I think what you say is absolutely true and really challenging, because as you say, very few of our nutrition programs really do look at a multi-sectoral approach to solving problems, which clearly are not just, for most nutrition problems, they're not just nutrition, there are other things too. Emily, this is a question for you, and I guess it's maybe for all of the panelists, but Purnima showed us the epidemiology to show that over the last, whatever it's 5 or 10 or 3 years, for many of the important interventions, our progress has been somewhat limited. And I guess, Emily, I'd ask you the question, when you did the review of the evidence for the 10 or 11 or other interventions, of course, most of the research that you examined were efficacy studies, where populations were not free living populations. They were populations that were in a research study. Yet we know that when you take an efficacious program and you put it into the free living population, the numbers don't look the same. Maybe a good example is that we've known for a long time that zinc is very important to decrease the morbidity from diarrhea. Yet if you look at the data, very few really successful programs on zinc in free living populations. There was an article in the New England Journal only in the last 6 months talking about 50% of the children who take zinc are vomiting. So I guess my question is, for the next Lancet series, do you think it might be possible to look more or at least as much into effectiveness as you did into efficacy for the leading interventions?
Yeah, I think it's a really great point, Stan, and it wasn't for lack of trying. I think all those reviews did attempt to summarize and synthesize evidence on effectiveness, but there are a lot of data gaps in that regard, and a lot of the supplementation interventions, for example, there's, as you mentioned, for zinc, there's really a lot more efficacy data out there. We did manage to summarize some effectiveness evidence. So for example, on food distribution or food basket programs. And we did see, even though there was quite limited evidence, we did see very positive effects of those. As well, we've done that big review looking at the effectiveness of fortification programs. And we saw important effects of large-scale fortification programs as well. So I think, we do have those to sort of supplement these these efficacy trials, but hopefully in the next update, we'll be able to provide even more real world evidence, as you said, to look at the impacts of some of these supplementation interventions in specific.
Other than the fortification, are there other of the 11 interventions, are there others where there's pretty good data on effectiveness, where we know that the research actually can be carried on into communities in a successful way?
Off the top of my head, I would say those are the two interventions, like the food basket and the fortification interventions, where there's the most. There's some where there's absolutely none because it's newer. For example, the lipid-based nutrient supplements. Others can correct me if I'm wrong. I don't think there's any community-based programs on those interventions yet. So certainly we'll keep an eye.
Great.
Emily, what about cash transfers?
Yeah, so cash transfers we had looked at. The review focused, at least the Lancet review, focused more on the direct nutrition interventions. So it was a smaller component, I would say, those sort of other sectoral indirect interventions. And I would have to, I can't say off the top of my head what those showed, but my understanding of the literature is that there's some mixed results around cash transfers and certain nutrition outcomes.
I would once again suggest to the audience that if they have questions to ask, please put them in the Q&A. We haven't had too many questions yet. I would ask all three of you, having gone through the process and looked at the results and have thought of this, were each of you surprised by what you found in the work that you did? Were there some things that you hadn't expected? Or was everything that you found sort of what you thought you were going to find? For example, the 10 nutrition interventions that you updated the literature and found that all 10 of them were still relevant, and you added an 11th one. But were there other surprises that you weren't expecting? Maybe I'd ask each one of the panelists to answer that question.
I mean, I would say something I was really surprised about was the lack of data on the adolescent subgroup, just because that's been such a current interest, and I thought there would have been way more data out there. There was really barely anything. Like, there's some preconception supplementation evidence where adolescents are provided iron folic acid, and I think we were able to show it improved hemoglobin, but beyond that, the data is still really lacking for that subpopulation. So I thought that was quite surprising.
Interesting. Any surprises, Purnima?
I wouldn't really say surprises, Stan, but I think it is. I mean, like Emily, I'm really disappointed about the data stuff, and I think for me, I think one of the most disappointing things on data is how even since we had the Lancet 10, there was a set of evidence-based interventions that was there all the way from the Lancet 2008 and then the Lancet 2013. And, we've just finished a review, for example, of South Asia to look at how many countries include all of those in their policies and programs. And they include practically all those interventions, but you simply don't have data to know how well those are going, how well people are being reached. And so, I think if we want to really move people to accountability, even on our nutrition core, interventions, the 10, the 11, or whatever number, we desperately need data on the coverage, the reach, and the quality of those interventions. I mean, we have not even scratched the surface on saying anything about the quality or effective coverage of, some of these nutrition interventions. So I think we have a long data road ahead of us, and I just feel like we have to close these data gaps maybe before we write the next Lancet Nutrition series.
That was actually going to be my next question for you. What was going to go into the next 2027 Lancet series on maternal and child undernutrition? So you think that's going to be it? Coverage,
COVID,
quality?
COVID.
COVID.
I think. Yeah.
Mm.
But just to build on Purnima's point, I think the surprise for me was just not an impressive of a change over the years. So it's exactly what you were saying, Purnima, that it could be better and it's not. And to me also, it speaks to what we are looking at, which is national trends and some of the subnational information is indicating hotspots and targeting those areas and really understanding maybe what Purnima, you were saying, the 1,000-day families, where are they and how do we get to them? Those are the kinds of efforts that are needed, and perhaps doing deeper dives even with our looks at trends in time. And where are they happening in a more granular way might be important. Thanks.
So
And there's a bunch of questions in the chat box, not in the Q&A, but in the chat box.
Okay, sorry. Where's my chat box? This is Susanna Atia to the panelists. What do you see as the role of involving agricultural science in the
now
further
there's
use? Sorry? What do you see as the role of involving agricultural science in the further use and study of the nutrient-dense foods that can be cultivated in the home or community environment? So the role of agriculture in basically maternal and child undernutrition, perhaps we can generalize that question.
Well, I can make a really quick comment on that, considering I work for a food policy institution.
Yes, you do.
But the most recent evidence reviews on the role of agricultural programs really, I think they signal us towards not expecting the earth from agricultural programs, but really focusing, and actually this relates to a question or a comment that Parul made earlier. What are the indicators that tell us, whether a sector is doing enough for nutrition or not? And I think, with agriculture, we really have to focus on the quality of diets and the diversity of diets. So I don't think we should be looking at, is it a solve the anemia problem or solve the stunting problem? But the challenge is really, are you doing everything that is possible in these agricultural programs, but also in policies and, other sort of more upstream things that happen in agriculture to get and make high quality foods more affordable for all. So I think we can hold agriculture accountable to dietary improvements, but I wouldn't go much further than that. So that's all I wanted to say on that one.
Do you think we work as a nutrition community? Do you think we work close enough with the agricultural community?
We could do more.
My sense is, my sense is, at least from my perspective, we don't really work very closely at all with the agricultural community, but maybe I have a skewed sense of that working from a big city and a hospital.
I can add to that. I just think there are also, obviously as nutritionists, I think we would like to promote the consumption of diverse, locally available foods and diets. That would be ideal, but there are subsets of populations, like for example, in urban slums that I think don't have access and have to deal with market fluctuations. And so I think for that reason, we can't rely only on agriculture to kind of improve the availability of diverse foods.
Fair enough. Dr. Buddha has asked a couple questions, or actually maybe response to some of the answers to date. There is evidence on cash transfers, weight gain, and some effects from CCTs. Effectiveness, the current range of such evaluations is limited, but there is evidence BEP in pregnancy where the food supplementation programs show effects in the same direction. He also goes on to say that the exemplars approach will probably yield better evidence for change. Emily, any comment on that, or you would probably agree?
Yeah, no, I'm glad he supplemented my answer on the cash transfer bit. But totally agree. I think the exemplars, this kind of new way of looking at evidence, will be really important moving forward.
And Pearl, Ruby CL asks the question, what is the reason for these data gaps? Is it lack of interest or understanding of need, or lack of know-how of how to fill in these gaps, or is it a lack of resources?
I don't know, at some level, yes to all of them, in the sense that prioritizing what indicators to monitor systematically over time. I talked about antenatal care and health systems that provide a whole range of antenatal care services, but nutrition services within that has been lacking for a long time. And not having people look at the nutritional services and monitor them and look at change related to that is part of that issue of lack of interest or understanding the need to combine these together with the other interventions. And then of course, lack of resources, because think about like how the demographic health surveys get done and in which places and when, and that, you know, the gaps there as well. The indicators that we use definitely need more work. There's lots of actually work ongoing right now, some of it funded through the Gates Foundation on improving both the indicators themselves, but validating them as well to create better ones to track the intervention coverage issues as well. So.
Thank you. Purnima, this is a question about India. This is from Mehak Thind. Thank you for the amazing seminar. My question is for Dr. Purnima. What is the role of the local community surrounding impoverished societies in India? What role do they play in promoting maternal and child nutrition? So it's a question about what is the role of local communities in India?
There is actually quite a lot of work going on with, programs such as local women's groups or, livelihoods programs in local areas, social accountability programs. So I think there's actually quite a lot that local communities can do, but, there's certainly a part of me that feels that, when communities are stressed, when you have impoverished societies where a lot of children are malnourished, it usually also means that the local communities themselves are stressed. There are challenges with getting resources, income, services, often they are. So the challenge in designing and working with communities is sort of understanding what is most doable and what is most valuable for local communities to be spending their time on. I think there have been some interesting findings, for example, with social accountability, where local communities have discussed whether they get all of the programs and services that they're entitled to, and then, try to resolve some of that. But one needs to think a little bit harder, I think, about why are those societies impoverished in the first place, and what is it that the rest of society can and must do to alleviate some of the structural constraints that lie there. And I think, therefore, that we need that to be in constant conversation and constant tension, because you can't leave the solving of problems that are because of, perhaps long decades or centuries of neglect to the people who've been neglected themselves. So I think there's a lot of interesting things happening, and just a lot to continue to learn about on that front.
In 2008, in the Lancet series, here's a quote there from the series: "The international nutrition system, made up of international and donor organizations, academia, civil service, and the private sector, is fragmented and dysfunctional. Reform is needed so that we can perform key stewardship functions, mobilize resources, provide services in emergencies, and strengthen capacity in low-income and middle-income countries." all three panelists, what do you think? Have we made progress since 2008 in getting those responsible for change to be working together better, to maintaining their stewardship functions, mobilizing resources appropriately? I guess my question is, have we made enough progress? It's hard to be optimistic today, and for reasons that we're all really familiar with. But on the assumption that today won't last forever, can we be optimistic over the next 5 to 7 years that more will happen, that more changes will occur, based on our understanding of what the issues are and how to solve the problems? And I think we are in a position now, as we have been in for a long time, that we know a lot of the solutions. We just aren't quite sure on who is responsible for putting those solutions into action. Are you optimistic? Is the future bright? Again, not the future tomorrow, but let's say a year from now.
I mean, I personally think we have made a lot of change since 2008, and nutrition has become more of a focus globally. And I think more people are aware that it's a multi-sectoral issue now. COVID has thrown a bit of a wrench in our plans, I think, and I think you can look at it in one of two ways. I worry that it's going to set back progress, but as well, it could act as a kind of inflection point, or a focusing event for nutrition. And so perhaps we can use it and spin it in a positive sense. But I think there's a lot of evidence, there's a lot of efficacy studies, and we kind of know what works. But I think now more effort needs to go into having concurrent implementation research to go along with it, to understand in a real world setting, what are the barriers? Are they at an individual level? Are they, is there not enough political will? So I think we kind of need to move towards that type of research as well to see more progress in the next decade.
Thanks, Emily.
I agree with Emily. I think there has been progress made. And when I see examples, especially from the subcontinent, I feel encouraged. The slide that Purnima had on all of the things that have been put in place, the national nutrition missions, and that's clearly indicating that someone's listening to this at the national level, and recognizing the importance of nutrition to a whole range of, to development in general, which is what we've been preaching for a couple of decades. The example in Pakistan, where there is a huge new program called the EHSAS program, which is integrating a whole range of interventions targeted to the first 1,000 days. And there are lots of consortia and groups that have been formed over the past 2 decades or so, just working hard at trying to advocate and gather interest and talk about resources and talk about financing for nutrition, et cetera. So I think that the momentum has been there, and I hope it continues in the COVID context, as Emily was saying. Thank you.
Yeah, and for me, same, I think we've come a very, very long way in the last 10 to 12 years. The challenge in as I look forward here is, of course, I think the pandemic is really stressing, countries right now in more ways than just health and nutrition programs, as we know. So that recovery is going to take a while. But nutrition has been on the agenda globally in multiple sectors. You rarely hear conversations about social protection, about agriculture, even about health, without sort of nutrition being bundled into that. So I think we've done remarkably well at creating a massive coalition for the issue across sectors globally, as well as a lot of support by not just political leaders, but I would say leaders through the systems for implementation and beyond in countries as well. The challenge will definitely be to keep the momentum, to get the nutrition interventions themselves be delivered with scale and quality and equity, but to not forget that improving nutrition takes more than nutrition programs. And, that I think is still a big challenge, getting people to sort of really dig in also on the indirect pieces and to continue to work on the nutrition programs as well. So I think, but I'm optimistic. I think we have, more unified voice and more dialogue and much more ownership in countries of the issue. And that's what really matters, more than anything else is do national and subnational governments own and care about the issue.
Thank you. I'm so pleased that all three of you were optimistic in your outlook for the future. I too am optimistic, and I think at this particular time for our audience, it's important for us to be honest and optimistic about the post-COVID era. We will have to work hard to get things rolling again, I think, but I do agree that we've made progress, and we must be optimistic about the future. I would like to thank all of you, all three of you, not just for your presentations today, but for your incredible dedicated work to improving the lives of children and their families, particularly their mothers, over the last 10 and 20 years for at least two of you. And you've made a huge contribution, not only today in our short 2-hour presentation, but throughout your lifetime. And I'm greatly appreciative of having all of you as my colleagues and friends. You've made a huge contribution. And on behalf of all of us, thank you so much for both presenting today, wonderful presentations, your thoughtful answers to the questions, and more so for your contribution over a long period of time to improving the lives of children and their families. Thank you so much. I wish the audience, thank you audience for your questions. I wish the audience good health and safety until we're through this very difficult time. And of course, for our three speakers, thank you so much for participating. Great seeing my friends again. And hopefully soon we can get together. Big hugs for all of us, and best of luck for the future.
Thank you.
Thank you very much.
Thank you to you all. Thank you for the opportunity.
Thank you so much.
And with that,
everyone.
Halit, thank you very much. And we will leave for the rest of our day now. So again, thank you all so much for your presentations and for your contributions. Take care.
Bye.
Bye-bye.
Thank you.
Bye.